You are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. A 35-year-old man presented to the emergency department of a hospital with a 3-day history of progressive pulsating protrusion of his right eye. Now, after this, history, this patient, yes, also based on his medical records, it was realized that he had hyperlipidemia and also hypertension. Yes, one thing that was observed, or this patient actually made known to the clinician, was that the pulsating nature of the right eye synchronized with, of course, his heartbeat. So anytime his heart was beating, yes, the protrusion of the eye was also evident, felt by this patient. So these are the points that we have over here. This patient presenting with some of these things. Now, the first question is that what is the name given to, of course, these symptoms or these signs that this patient is presenting with? My friends, your answer is pulsatile proptosis. Pulsatile proptosis or pulsatile exophthalmos, because at the end of the day, we are saying that it was protruding, and was progressive. The pain and of course the severity of the situation was increasing with time, and then at the end of the day, it was protruding. So that is one thing, and then it was synchronizing with, of course, his heartbeat. Now, the next question that I want to ask over here is that what is the clinical diagnosis, definitive clinical diagnosis, as far as this patient's condition is concerned? And my friends, your answer is carotidocavernous fistula. Carotidocavernous fistula. So between the internal carotid artery, and of course the cavernous sinus, a fistula has formed. So cavernous fistula, a connection has been created. So that's the first thing I want you to know. Now, the next question that I want to ask, which is the third question, is that what other presentations, what other conditions who mimic this pulsatile proptosis as being who mimic actually this carotidocavernous fistula? That's actually the question. So that's it. And my friends, there could be other things. So what's the differential diagnosis? So you need to look at other things we could mimic it so that we can clearly distinguish or rule them out. And my friends, there are two more things which can have similar presentation. And then, of course, we debunk them, why they are not consistent with this case study. The first one is, of course, some kind of exophthalmos due to, of course, a thyroid condition. Now, this one is not due to a thyroid condition like Hashimoto's thyroiditis, presenting with that kind of grave disease and then eyes protruding. Because with that one, oftentimes, usually they are bilateral. But this time we talked about only one of them. And then also those ones, that kind of condition, there will not be any, protruding or pulsating nature. Pulsating nature of what we call the, eyeball. It will not be synchronizing with the heartbeat. So that's one thing. Now, the other thing which needs to be ruled out, is actually something we call orbital cellulitis. Orbital cellulitis. Yes, we are in the orbit region, but that's not the case. Because whenever there's cellulitis, one thing that you need to understand is that an infection is in there. And so if there's going to be an infection over there, then of course one thing that is clear is that there will be erythema, there will be redness over there, there will be edema over there, and of course that kind of pain, the fever, okay, that will be the presentation. But these ones were not, mentioned in this case study, and therefore rule, this kind of Hashimoto's thyroiditis, for instance, in the case of Graves' disease, or even, in the case of orbital cellulitis. And so your definitive diagnosis, as far as the pulsating nature of the eyeball, which is progressive, is concerned. Okay, so your answer is of course the carotidocavernous fistula. And so the next question, where is the fourth question, is that we want to understand what is the pathophysiology as far as this condition is concerned. And so the point over here is that understand that the medical history of this patient, okay, is consistent with of course hypertension and of course hyperlipidemia. And so it makes sense that of course one important artery, okay, which relates to this, of course, which actually runs inside this cavernous sinus, and also it's also in relation to the roof of the cavernous sinus, is, my friends, some people call the internal carotid artery. And so for this reason, if there's too much pressure in there, then this internal carotid artery could rupture. Yes, it could be aneurysm or whatever. Yes, it could rupture because of the increased blood pressure over there. Okay, now when it ruptures, what will happen is that there's that kind of subsequent fistula formation, because at the end of the day, this internal carotid artery is a content of what we call the cavernous sinus. So there will be that kind of connection. But understand that the internal carotid artery is an artery, and therefore it carries blood with high pressure, oxygen-rich blood with high pressure. And then of course the cavernous sinus it carries, yes, venous blood, okay, with low pressure. And so what will happen is that the pressure will move from the blood, okay, running in what we call the internal carotid artery, will be moving, okay, mixing with that of what we call the venous blood in, of course, the cavernous sinus. Okay, and one important thing which we are aware is that by way of relation, the cavernous sinus relates anteriorly to what we call the superior orbital fissure. And so for this reason, the content by way of the blood, in this case venous blood and of course arterial blood mixture, okay, will be pushing, okay, the eyeball through what we call the superior orbital fissure. And so that is when you'll be seeing the pulsating nature, because arteries, okay, the blood that they are carrying with high pressure, okay, moving with the pulse of the heart. And so what's going to happen is that the patient eye will be pulsating. Okay, that is what we'll be seeing as the presentation. That becomes the pathophysiology of what we call the carotidocavernous fistula. Okay, that is the important one which I want you to become aware of. Now the next question is that, now God saw it coming that the pressure in the internal carotid artery could be so enormous that some of these, rupture and whatever could happen. And so what did God do? Even with that, we are seeing some of these pathologies, but God did something to reduce the pressure in, of course, the pressure that it gets into the cranial cavity, okay, of the internal carotid artery. And that is something we call carotid siphoning. And that is why I told you that this same internal carotid artery, yes, gets inside, of course, the cavernous sinus, and then makes a loop, and then also gets into the roof, okay, relates to the roof also. And so by so doing, the pressure that it gets into the cranial cavity, essentially, yes, will be reduced. But even with that, this rupturing of the artery, yes, is still seen. My friends, the last question which I want to ask, and then we bring our meeting to a close, is that what will be the complications if, for instance, if carotidocavernous fistula is not, corrected? Yes, what is going to happen? And my friends, your answer is that yes, mainly it may lead to what we call vision loss. Essentially, vision loss, yes, is the most important complication as far as this condition is concerned. Because at the end of the day, the pressure over there may compress on what we call this, this thing that we call an optic nerve. Okay, the increased pressure may compress on it and may even cause it, not to really, transmit the signals, and therefore vision loss is going to, be evident. And my friend, there's something we call still phenomenon. Okay, still phenomenon. So, for instance, the blood that is supposed to get to the brain, because this internal carotid artery is losing blood, then the brain wants to, I mean, the blood, arterial blood, which is supposed to supply the brain, okay, some of it, okay, will be stolen, okay, into this internal carotid artery to make it up for the loss that it is losing to, of course, the cavernous sinus. And my friends, by so doing, the likelihood of ischemia to the brain, okay, cerebral ischemia, yes, could happen. So my friends, these are the things which I want you to understand, yes, I mean, by way of the case studies that we are doing. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.